Welcome back to the Pharmacology Vault, where drug classes aren't just memorized, they're understood. In this episode, we're diving into a lesser-known but fascinating class of pharmacological agents, ganglionic agents. These drugs target the autonomic ganglia, the command centers between your brain and your organs. Though not commonly used today, they're essential for understanding the pharmacological regulation of the autonomic nervous system. Let's unlock the basics first. Ganglionic agents are drugs that act at autonomic ganglia, those relay stations where preganglionic neurons communicate with postganglionic neurons. They work on nicotinic receptors, specifically the NN subtype, and since autonomic ganglia are part of both the sympathetic and parasympathetic systems, these agents can affect both branches simultaneously. These agents act in two major places: autonomic ganglia, where they interfere with neurotransmission between the pre- and postganglionic neurons. Adrenal medulla, which is basically a modified sympathetic ganglion that releases epinephrine and norepinephrine into the bloodstream. So, whether it's adjusting blood pressure or triggering hormone release, ganglionic agents can influence it all, centrally and systemically. Ganglionic agents are classified based on their action at the nicotinic NN receptors. Ganglionic stimulants. These activate NN receptors, increasing autonomic outflow. Ganglionic blockers. These inhibit NN receptors, suppressing both sympathetic and parasympathetic tone. Let's look at each group more closely. Let's now break down ganglionic stimulants, the drugs that activate nicotinic receptors at autonomic ganglia, stimulating both sympathetic and parasympathetic pathways. These agents work by binding to NN receptors, the nicotinic subtype found in autonomic ganglia, not to be confused with the NM receptors found at neuromuscular junctions. Selective nicotinic agonists, ganglia-specific. These drugs selectively stimulate NN, neuronal-type nicotinic, receptors in autonomic ganglia, without significant muscarinic activity. They're primarily used in research or in very specific therapeutic contexts. Examples include nicotine, low dose, stimulates autonomic ganglia, initially increasing both sympathetic and parasympathetic tone. Lobline, a plant-derived nicotinic agonist with historical interest in smoking cessation. Dimethylphenylpiperazinium, DMPP, highly selective for ganglionic NN receptors, used experimentally. Trimethaphan, TMA, another lab tool for autonomic studies. Varenicline, a partial agonist at NN receptors, clinically used in smoking cessation as it reduces cravings while blunting nicotine's full effect. Non-selective cholinergic agonists, both nicotinic and muscarinic activity. These agents are not selective. They stimulate both nicotinic and muscarinic receptors, leading to widespread parasympathomimetic effects. Examples: acetylcholine, the natural ligand, stimulates all cholinergic receptors but has a very short half-life. Carbachol, more stable, used in ophthalmology for its dual muscarinic and nicotinic action. Pilocarpine, mainly a muscarinic agonist but can have some ganglionic effects at high doses. Anticholinesterases, indirectly increase ACH levels at all cholinergic synapses, including ganglia. These non-selective agents activate the ganglia indirectly or broadly, and their clinical use is typically driven by their muscarinic effects rather than ganglionic stimulation specifically. Now let's talk about ganglionic blocking agents. These are drugs that inhibit signal transmission at autonomic ganglia by targeting nicotinic NN receptors. By blocking these ganglionic nicotinic receptors, these agents suppress both sympathetic and parasympathetic output, essentially flipping the master switch of the autonomic nervous system. Competitive blockers, true antagonists. These drugs work by competing with acetylcholine for binding at the NN receptor, but they don't activate it. The result? Transmission between preganglionic and postganglionic neurons is halted. They are further classified into chemical subtypes, quaternary ammonium compounds. These are charged molecules that don't cross the blood-brain barrier, so their action is peripheral. Examples: Hexamethonium, the first ganglionic blocker ever developed, once used for hypertension, now obsolete. Pentylinium, longer acting, previously used in controlled hypotension during surgery. Amines. These are uncharged and lipid-soluble, so they can enter the CNS and may produce central side effects. Examples: Mecamylamine, one of the few ganglionic blockers that was used orally for hypertension, can cause CNS effects. Pempidine, lesser known, experimental interest only. Monosulfonium compounds. These are used parenterally and have short, rapid actions, making them suitable for temporary interventions. Example: Trimethaphan camphorsulfonate, used intravenously for controlled hypotension during surgery, or rarely, in autonomic dysreflexia. Persistent depolarizing blockers. These are a bit different. Instead of blocking the receptor like competitive antagonists, they overstimulate it, leading to persistent depolarization and receptor desensitization. This keeps the ion channel open, but prevents further action potential transmission, effectively causing a functional block. Examples: Nicotine, in high doses, paradoxically acts as a stimulant at low doses and a blocker at high doses. Anticholinesterases, in overdose, by flooding the synapse with acetylcholine, they overstimulate and eventually desensitize the nicotinic receptors. So in summary, ganglionic blockers shut down autonomic tone by either competing with ACH or depolarizing the receptor to exhaustion, cutting off both sympathetic and parasympathetic signals. These drugs are rarely used today due to side effects, but they were critical in the early treatment of hypertension and in surgical settings for controlled hypotension. Now that we've explored the mechanisms and classifications of ganglionic agents, let's take a look at their clinical uses, both current and historical. While these drugs aren't first-line therapy today, they hold a unique place in pharmacological history and are still relevant in a few niche applications. Let's start with the most clinically relevant use today: smoking cessation. Nicotine, when delivered in controlled low doses via patches, gum, or lozenges, acts as a ganglionic stimulant. It helps reduce withdrawal symptoms and cravings by partially stimulating nicotinic receptors, mimicking the effect of smoking, but in a much safer way. Another effective option is Varenicline, a partial agonist at nicotinic NN receptors. It works by providing enough stimulation to curb cravings, while blocking nicotine's full effects if a person smokes. This dual action makes it one of the most effective agents for helping people quit tobacco. Many ganglionic agents are used not in clinical practice, but in pharmacological research to study autonomic function and receptor behavior. Common lab tools include Lobline, DMPP, dimethylphenylpiperazinium, TMA, tetramethylammonium. These agents help researchers understand how the autonomic nervous system reacts to stimulation or blockade at the ganglia. In the past, ganglionic blockers were used to deliberately lower blood pressure during surgeries, a process called controlled hypotension. The goal was to reduce bleeding in the operative field. Drugs used included trimethaphan, pentylinium, hexamethonium. These agents blocked both sympathetic and parasympathetic tone, but they're rarely used now due to their broad side effects and better alternatives. Before modern antihypertensives were available, ganglionic blockers like hexamethonium and mecamylamine were used to manage acute hypertensive crises. While effective, they caused significant side effects, including orthostatic hypotension, dry mouth, and constipation, which led to their replacement by safer, more targeted agents. In certain research models, anticholinesterase stimulants like DMPP have been used to simulate or diagnose cholinergic crisis, especially in studies of autonomic function or acetylcholine dynamics. This is not a routine clinical use, but it underscores how ganglionic agents help expand our understanding of pharmacology. Finally, in rare cases of autonomic hyperreflexia, a life-threatening condition seen in patients with high-level spinal cord injuries, trimethaphan may be used to suppress the exaggerated autonomic response. However, this is highly specialized and rarely needed with today's improved management strategies. And that's your roundup of the clinical applications of ganglionic agents, from nicotine patches to research tools, and from historic surgery protocols to spinal emergencies. If this helped clear up a tricky topic, don't forget to give it a thumbs up and hit that subscribe button. Your support keeps this vault open and growing. Until next time, stay sharp, stay curious, and keep unlocking the vault of pharmacology.